Welcome to the Resuscitation and Emergency Medicine Diploma, a premier one-year online program designed to equip you with advanced knowledge in the resuscitation and emergency medicine field. Our aim is to provide you with high-quality educational materials and up-to-date resuscitation and emergency medicine scientific knowledge, delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top resuscitation and emergency medicine experts online? Our program brings world-class instruction directly to you, no matter where you're located. Through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback, you will receive the high-quality education that is going to augment and complement your in-person program, all from the comfort of your home or workplace. Our Resuscitation and Emergency Medicine program offers a comprehensive diploma structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1-year period. Balancing work, life, and professional development can be challenging. Our Resuscitation and Emergency Medicine Diploma is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering basic and advanced life support to specialized training in airway and mechanical ventilator management, to advanced trauma and burn life support, ECG interpretation, and arrhythmia management and ER radiology, orthopedics, toxicology, pediatric and obs-and-gyn emergencies, and ER procedures, you will develop the essential skills to manage ER patients at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized American Association of Continuing Medical Education accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of EM professionals who have transformed their careers with this diploma. Don't miss this opportunity. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our Emergency Medicine and Resuscitation Diploma webinar. Today, we have a very special webinar and also very special guest speakers, and we are focusing on ACLS. Last month, we had a webinar trying to be updated with the last guidelines regarding the ACLS, both in adults and in children. And today we are focusing on the ACLS. We have Dr. Haitham Khalifa from Saudi Arabia, Dr. Amr Al-Buhin from Doha, Qatar, Dr. Ahmed Al-Sunusi from Jeddah KSE, and Dr. Muhammad Abbasi from Norton University in Canada. So very, good diversity between moderators and speakers. And here is our humble agenda after this intro. Dr. Haitham Khalifa will have a very interactive and interesting case-based discussion. So please feel free to try to answer. There will be a poll, so you can vote in the poll. Then Dr. Amr Al-Muhin will give us the last updated guidelines for ACLS in adults. Then Dr. Ahmed Issunusi will give us the up-to-date information for ACLS in children. Again, Dr. Muhammad Abbasi is going to moderate the session, trying to help the speaker to answer the questions. Again, Dr. Haitham from MedPro and Sono School, and he is emergency medicine consultant in KSA right now. And Dr. Amr Muhin, he is associate professor at Qatar University. Dr. Ahmed Sunusi, he is emergency medicine consultant at International Medical Center in Jeddah. And Dr. Muhammad Abbasi is emergency medicine associate professor at Northern University, Ontario, Canada. If you are interested to join our emergency medicine and resuscitation diploma, please go ahead and apply. The door is still open, and please take advantage on the 10% discount using promo code webinar10. Housekeeping stuff here. If you have any question, you can type it in the QA box. All attendees should receive attendance certificates by next week. If you would like not only to hear the lecture, but also to have a transcription of whatever the speaker is talking about, you can enable or activate the show caption option. Again, our next webinar will be on Monday, July 13, and we will be focusing on advanced trauma life support, so ATLS. So we started with the basic, then advanced, then we'll move next month to the ATLS. And we are not here to teach you the basics. We are here to help you to manage your patients better by challenging this clinical knowledge. We are trying to have brainstorming, critical thinking, so you can improve your patient's outcome. Because if we don't think, we are going to sink. And with that, I'm going to let Dr. Muhammad Abbasi to introduce our first speaker, Dr. Haitham Khalifa.
Thank you, Dr. Amr, for the presentation. It's my pleasure today to introduce our first speaker, Dr. Haitham Khalifa. He is an emergency medicine consultant and the managing director of Soon School, Egypt. Mike is yours, Dr. Haitham.
Thank you, Dr. Muhammad, Dr. Amr, and all my colleagues. Actually, I am excited to be with you today. I'm an emergency consultant at King Fahd, a specialized hostel. Thank you for joining us today. In the next 15 minutes, we will review the most important ACLS updates through a real cardiac arrest case. Rather than reviewing all the guidelines, we want to focus on the updates that we daily use in our emergency practice. And you have to ask yourself a question. If this patient arrived to my department today, would I manage him differently after the 2025 guidelines? Before we start, remember that the key message, the biggest ACLS updates is not a new drug or a new device. It's highly focused on the high-quality CPR, early defibrillation, and better post-resuscitation care. So let's start with our first scenario. 45-year-old female with chest pain, sweaty, suddenly collapsed in the emergency department. She is unresponsive. CPR initiated immediately and the monitor show ventricular fibrillation. Please be ready with pulling. The monitor show ventricular fibrillation. So the first pull, what is your first priority? Giving epinephrine, amiodarone, defibrillation, or intubation. Please select the single choice. What is your first priority in the ventricular fibrillation cardiac arrest? We have, please everyone, share with us?
I think the vast majority, Dr. Haitham, are going for the DC. So ventricular fibrillation need fibrillation.
Yes, exactly. 88%. Thank you. Ventricular fibrillation in the shockable rhythm is the most important intervention, is immediate defibrillation. No medication has ever been shown to be more important than the ventricular fibrillation in the cardiac arrest. And this has remained unchanged in the 2025 guidelines. Early defibrillation, high quality CPR, and team-based resuscitation. So now, defibrillation delivered to our patient, CPR is ongoing, team preparing medication. So, what is the preferred vascular access during the adult cardiac arrest? This is the second poll. What is the preferred vascular access during adult cardiac arrest? Tibial interosseous, humeral interosseous, peripheral IV line, or central line? Please select the single best choice.
I think there is a split between C and D. The vast majority choose either peripheral IV or central line.
Yes, so what is the best single choice? What is the result? Okay, 58 is peripheral IV line. Exactly, according to 2025 guidelines, intravenous access remains the preferred route for medication administration during the cardiac arrest. If you can't get the IV access, intraosseous access is acceptable alternative and shouldn't delay the treatment. So IV access, still the first line, still the preferred line, and don't delay the medication. You have to go to intraosseous if you couldn't find the IV access and not the central line. Okay, so in our scenario, we establish the IV access, we give epinephrine, CPR is running, multiple shock delivered, but the patient is still in refractory ventricular fibrillation. So what would be the priority now? This is our next poll. What is the priority in the refractory ventricular fibrillation? Is it epinephrine, immediately sodium bicarb, or the third question C must be to do high quality CPR and to do the refractory, to do the defibrillation, and the last one is intubation. So in the answer, the B is repeated, but the C is the high quality CPR and defibrillation. So the question here is repeated. If you want to select C, C is high quality CPR and the frequent defibrillation. A, epinephrine, B, sodium bicarb, and D, intubation. So what would be your choice? A or B or C or D? Yes, exactly. The answer should be the C answer. It's not written here. It's written by mistake, but it is the C answer to focus on the high quality CPR and to give shock once the patient is shockable. So this one is the most important message in the guidelines. Despite there is another ways like sequential defibrillation and vector change defibrillation and heat up CPR, all of this has no evidence till now to be better than the high quality CPR and the effective defibrillation. So in the refractory ventricular fibrillation, priority to high quality CPR, defibrillation, and reversible causes. So let's go to next poll. The fourth poll, double sequential defibrillation is. What is double sequential defibrillation? Is a standard of care. Is it recommended after 3 shocks? It has uncertain benefits or better than the conventional shock. Did you hear about the double sequential defibrillation? And what do you think about it? Is it now a standard of care? It is recommended after 3 shock, uncertain, or better than the standard shock or the conventional shock? What do you think?
I think if the vast majority didn't hear about it, they should be uncertain about the benefit.
Yes. Okay, exactly. This is the true answer. Uncertain benefit until now. We have just trials about this technique. The It is not established until now. The double sequential, yes, is uncertain benefit. The double sequential shock is to use like two defibrillator, two pads at the same times. And there is also what's called vector exchange defibrillation. We change the position of the pads to anterior and posterior, maybe for different anatomy, maybe to get a better shock to the heart. And another technique also in the refractory ventricular fibrillation is elevating the head up in the CPR. All these techniques, all these three advanced strategies have gained attention in refractory ventricular fibrillation, but still remains insufficient for routine use until now. Okay, let's go to the next question. After successful return of spontaneous circulation, what is the target mean arterial blood pressure after ROSC? What is your target if you are using vasopressors? What will be your target in the MAP, in the mean arterial blood pressure according to the new guidelines? 55, 60, 65, or 80 millimeter mercury. What is your choice? What is the target MAP after ROSC?
About 74% has chosen 65 millimeter mercury. I think this would be the good answer. Always target for a MAP of 65.
Yes, this is correct answer. It is 65, and now exactly 65 millimeter mercury. And now the post-ROSC hemodynamics, according to the new guidelines, focus on MAP more than 65, saturation of oxygen from 90 to 98, and PaCO2 from 35 to 45, and temperature control more than 36 hours, 1 day and a half. This is the post-ROSC recommendation in the new guidelines. So saving the patient does not end with the ROSC. Post-cardiac arrest care is where many of the 2025 updates are focused. Also, one of the public health updates in the 2025 is expanding the access to naloxone because there is a lot of cardiac arrest due to narcotics or morphine use in the different countries. Now also the mechanical CPR device remain useful in the selected situation like the locus machines and auto pulse machines. It is not routinely recommended, but it is considered in a special situation like in ambulance transfer while in the cath lab, cardiac arrest in the cath lab, also using the ECMO CPR, and in unsafe CPR environment, they recommend the use of mechanical CPR devices, but now it is not a routine. It's still the high quality manual CPR for the routine use. And now we are in a new era of the ECMO CPR. The ECMO CPR for specific patients and for selected patients and for special circumstances is very effective and has rule now in the cardiac arrest, where you are artificially managing his circulation and his ventilation until you can fix the reversible cause of shock in your patient. But this is in specific situations and in specific and well-trained staff. Now they are recommending in some situation the eCPR or the ECMO with CPR. Also, it is used in the hypothermic cardiac arrest with HOPE score. with Hope score. This is a score that help you to select which patient with hypothermia is candidate for the ECMO with CPR. This is also added to the new guidelines. If you have a patient who has left ventricular assist device, don't ask the patient has pulse or not, because this patient hasn't pulse. But when to start the CPR, you have to start CPR if the patient has no perfusion. If no signs of good perfusion in the patient with LVAD, you have to start CPR in this patient. And finally, the ACLS highlight the use of point-of-care ultrasound, especially after ROSC, to find the cause of the cardiac arrest and correct this cause of cardiac arrest, like the hypovolemia, the pulmonary embolism, the tension pneumothorax, and different reversible causes. And also recommend early PCI if the patient has suspicion of any cardiovascular disease or need to be revascularized. Education science updates is a new focus in the new guidelines, using the CPR feedback devices, team leadership simulation, and using games and training. And finally, the take-home message, early defibrillation remains critical. Use the IV access, and in the refractory ventricular fibrillation, high priority to CPR and reversible causes. In the post arrest in ROST, keep the mean arterial blood pressure above 65, temperature control more than 36 hours, and naloxone never delays CPR. Mechanical CPR is good but selective and not routine, and better training saves life. Thank you.
That's a great interactive presentation. Thank you so much, Dr. Haytham, for that. And before we move to the next speaker, we have just a 2-minute description presentation about our upcoming resuscitation and emergency medicine diploma. If can Dr. Haytham stop sharing so we can share the next presentation. We are going to start the diploma in a couple months. So we'll give you a description. The diploma is not based on monologue or one direction education, but it's based on clinical case scenarios, a lot of interaction and case-based discussion.
Hello, everyone, and welcome to our World Institute Critical Care and Emergency Medicine Resuscitation and Emergency Medicine Diploma, which is very unique flagship program for 1 year, focusing on the basics and advanced knowledge in resuscitation and emergency medicine. And we have gathered international expertise from all over the world to help you to understand the foundation and the novel techniques and clinical knowledge in resuscitation and emergency medicine. This is not based on monologues or lectures, but based on bidirectional education with dialogues and engagement of our fellows throughout live sessions, clinical case scenarios, MCQs, and journal clubs. Because we know that your retention rate is very low when it comes to giving you lectures or giving you materials to read, we try to involve you throughout the whole year of this diploma, doing demonstration, having discussion, and trying to apply this clinical knowledge into your clinical practice, and also helping you to teach others this knowledge to have the best retention rate. So all of our fellows in this program are going to receive very high quality scientific materials on weekly basis, and they have to turn on their assignments and tasks before the end of each week. And all of their activities are monitored in the SMART platform. So each of them will have a username and password, and will have access 24/7 to our high-quality educational materials. So one of the major aim of this diploma is to identify our fellows' weaknesses and to work on it and to empower and enlighten their strength. Again, we are aiming to let you to master the clinical practice and the training and resuscitation and emergency medicine throughout a smart e-learning process. And mastery doesn't come only with the basic knowledge, but it comes when you apply clinical knowledge into your practice. So it's 100% online program accredited by the American Association of Continuing Medical Education with 96 credit hours and is structured as 3 modules, 16 weeks each. Module 1 is focusing on resuscitation and life support. Module 2 will be focusing on core emergency medicine topics, and Module 3 will have advanced practice and procedures. Again, it's 1 year program, and it has every week new case-based discussions, MCQs, clinically based, and clinical scenario journal club, and also will have live webinars. Again, it's accredited for 96 credit hour by the American Association of Continuing Medical Education. And upon completion of this diploma, you will be graduated to a trainer and the mentor level in the emergency medicine field. So please join our growing community of emergency medicine physicians who are going to help their patients and hopefully improve their outcome. If you want to join, if you are interested, please feel free to join, and you can get 10% discount using the promo code of webinar 10. So this is going to expire soon, so please try to apply as early as possible and take advantage on this discount. Again, knowledge has no value until we put it into practice, and our aim from this educational program is not the knowledge itself, but the action. We are helping you to improve your clinical practice and your patient's outcome.
Thank you, Dr. Am, and thank you, Dr. Haytham. The participation in the poll was amazing. We want to keep the webinar interactive, so please, if you have any question, you can type it in the questions and answer section. We will do it afterwards. It's my pleasure to introduce our next speaker, Dr. Amr Muhin. He is an associate professor at Qatar University and emergency medicine consultant at Hamad Medicine Corporation.
Hello, colleagues. I'm happy to present in World Institute of Critical Care and Emergency Medicine. Today, we will discuss the new Adult Advanced Cardiac Life Support 2025 and what has been changed. So it is not reinvention of new guidelines, only refinement of some points we will discuss about from the timing of medication, early defibrillation, the importance of team approach, and the post-resuscitation care. So it emphasizes on fewer distractions and to how to perform better basics and how to have stronger systems of care. Why these points were changed? As they found that out-of-hospital cardiac arrest survival to good neurological outcome is only 10%. And in-hospital cardiac arrest survival is acceptable, is 24%, but a lot of points of gaps we want to fix, like when to give epinephrine or other medication. What about IV access? It is IV or IO. What about ventilation after return of spontaneous coagulation? And the team approach. So our goal is neurologically intact survival in the discharge, not only return of spontaneous circulation. Before starting, I want to review the adult advanced cardiac life support algorithm, which has not been changed a lot. So let us go to fundamentals. First of all, once we recognize there is cardiac arrest, we want to shout for help, activate emergency response. Whenever we are in the hospital, we will activate code blue. The fundamentals here emphasize on to start good quality chest compression, CPR, and to give oxygen as early as possible, and to attach monitor. Why to attach monitor or defibrillator? To recognize the rhythm, which is the most important point in resuscitation of cardiac arrest. Either the rhythm be shockable, ventricular fibrillation, or pulses VTAC, or non-shockable, asystole, or PEA. Let us discuss the shockable rhythm. Once we recognize there is shockable rhythm, the only treatment needed is shock. Deliver defibrillation, shock, and immediately start good quality CPR for 2 minutes and have IV or IO access. Then after 2 minutes, we will analyze the rhythm again. If the rhythm is still shockable, the only treatment is to deliver shock. Then start good quality CPR for 2 minutes. Here, we can give epinephrine in the new guidelines. After 2 minutes, we will analyze the rhythm. Still the patient in shockable rhythm, we will deliver a shock. And again, start good quality CPR. If it is refractory shockable rhythm, amiodarone can take a role here, or lidocaine. What about non-shockable rhythm? Non-shockable rhythm, as we said, this asystole or PEA. The only fundamental cornerstone here to deliver epinephrine as soon as possible. Then immediately start good quality CPR for 2 minutes. During that time, we will have access, either IV or IVO, and consider airway, advanced airway capnography to monitor the resuscitation. If 2 minutes passed, we'll again recognize what is the rhythm now. If it is shockable, we'll go to shockable rhythm. If it is not non-shockable, we'll immediately start CPR for 2 minutes and think about the reversible causes, 5H, 5T. As you want to see, 5H, as we all of us know, that are hypovolemia, hypoxia, hydrogen ion, this is pH, hyperkalemia, and hypothermia. How to diagnose that during CPR? The most important thing to do VBG. Easy, quick investigation to diagnose this 5H and to take temperature of the patient. 5 T's, first one is tension pneumothorax, second one is cardiac tamponade, any toxins, pulmonary thrombosis, coronary thrombosis. How to diagnose them? By history before arrest, and also point of care ultrasound. If we want to emphasize 2 investigations during cardiac arrest, are the VBG and point of care ultrasound. And still guidelines emphasize about high quality CPR and deliver shock whenever needed in shockable rhythm, and to minimize the interruption as much as we can. So this is the guideline. As you can see, there is no much new changes, but we will talk one before talking about changes, what was not changed. The new 2025 guidelines emphasize about these very important points. High quality CPR is a cornerstone that to maintain perfusion as much as we can to the vital organs. Early defibrillation, if the patient needs defibrillation in shockable rhythm. Early deliver shock. How to diagnose that it's shockable or non-shockable? Attach monitor as early as you can and diagnose it's shockable or non-shockable to follow the algorithm. If the patient is non-shockable, our main concentration is to diagnose why the patient has cardiac arrest and to diagnose and treat whatever reversible causes we can, like 5H, 5T, as we discussed. And the most important thing that it is not only return of spontaneous circulation, our target to have good post-resuscitation care, post-ROSC care, to have good neurological outcome. The top 2025 updates we will discuss now about the access, either intravenous or IO, timing of epinephrine, defibrillation modes, and system and introduction of new approach or new system survivorship that CPR coach. So let us talk about vascular access. All of us know that intraosseous is rapid access, and it gives us a rapid route for delivering the resuscitation medication like epinephrine. But evidence going with that intravenous has better outcome and a better chance for return of spontaneous circulation. So the message is clear. Early IV access is our aim, but if we didn't succeed to have early IV access, IO is a clear backup plan for access for delivering resuscitation medication. So try first IV access. If you failed, try IO access. Let us go to the next point. The timing of epinephrine. Timing of epinephrine is very important, as they found in shockable rhythm. Epinephrine can cause myocardial and coronary vasoconstriction, which will increase the oxygen demand of the muscle. So we have a clear pathway now. In shockable rhythm, the priority here for shock, giving shock, high quality CPR. If it is still shockable, give shock and high quality CPR, then epinephrine will come. But for non-shockable rhythm, epinephrine is the cornerstone, then high quality CPR. For the mode of delivery of shock. Recently, there is a lot of enthusiasm for new modalities for delivering shocks, like double sequential external defibrillator and retrochange defibrillator. But in 2025, adult cardiac life support emphasized that the normal pad position has better outcome. And the most important points to emphasize not the mode of delivery of shock, but the pad position and high quality CPR, the timing of delivering shock are more important. One, for the drugs in the cardiac life support, don't over-medicate patient. Here we emphasize that the only medication are approved, evidence-based, that will be beneficial, that epinephrine and amiodarone or lidocaine for refractory VF, but they didn't find any benefit of vasopressin over epinephrine. And also for other antiarrhythmic drugs, no evidence for better outcome to use beta blocker, procainamide, beryllium, or calcium or sodium bicarbonate. So the clear message here, don't over-medicate refractory VF. Focus on high-quality CPR and team approach. For airway and ventilation, we emphasize for the new adult cardiac life support 2025 that the first method for ventilation to be considered is bag valve mask. Then, if oxygenation is not enough, we will escalate to supraglottic. If not enough, we will proceed with definitive airway by endotracheal intubation, only if we have expert person to do that. And they emphasize clearly about avoiding hyperventilation. Hyperventilation can increase intrathoracic pressure, which will decrease the venous return and decrease the coronary perfusion, which will lead to decrease the chance of ROSC. For monitoring the quality of CPR, end-tidal CO2 capnography remains a gold standard to monitor the quality of CPR and also to pick the early signs of ROSC. Let us go for the most important point in the new guidelines about the post-resuscitation care. We want to return to the normal physiology of the patient as early as possible. For hemodynamics, the mean arterial blood pressure target, the temperature target, and what about oxygenation and CO2, and what about post-resuscitation maneuvers or the procedure we wanted after the ROSC. Let's talk about hemodynamics. Our main aim to return to normal physiology quicker, as this will improve the quality and the neurological outcome. So our aim to maintain mean arterial blood pressure more than 65 millimeter mercury. So consider early arterial line, IV fluid, give any vasopressor, epinephrine or norepinephrine are acceptable to maintain mean arterial blood pressure above 65. Respiration, we want to maintain normal oxygenation between, our target is between 92 to 98, not over that and not lower than that. And for CO2, maintain it normal between 35 and 45. So our aim to avoid hypoxia or hyperoxia and avoid also hyperventilation. The new guideline emphasizes for early 12-lead ECG to diagnose if the patient has acute myocardial infarction as a cause of arrest, for early definitive PCI treatment, and to do early point-of-care ultrasound echo to find any reversible causes which can lead to, again, arrest. So these are the main points in the hemodynamics. About temperature control, the main aim now is that to keep the patient temperature between 32 and 37, and the message here, prevent hyperthermia, fever as much as you can, as this will decrease the neurological outcome. Fever, increase the oxygen requirement, so prevent fever as much as you can. So there is two approaches, that either to keep the patient in normal temperature or to keep him in hypothermia for 36 hours. Both are evidence-based. If we keep the patient in hypothermia, our aim to rewarm it during the first 72 hours to return to normal temperature. What about special circumstances? Special circumstances during CPR. Naloxone is still the cornerstone if we suspected any overdose of opioid, but never at the expense of high-quality CPR. In pregnant ladies, if the patient in arrest, left lateral uterine displacement is very important, and also consider early definitive airway. For selected reversible causes like massive pulmonary embolism or severe toxidrome, other modalities of CPR is highly considerable at that time, like VA ECMO or extracorporeal CPR, eCPR, is very important to consider during these special circumstances. One, the recent new adult cardiac life support guidelines emphasize about the team approach. As we mentioned, team approach is the most important point that will lead to good quality cardiopulmonary resuscitation and good quality ROSC with good neurological function. So optimize this team performance in resuscitation, and they introduce a new role of CPR coach who will focus on monitor of the feedback, monitor the quality of compression, depth and rate, and decrease the interruption as much as he can, and give time for team leader to focus on the reversible causes 5H, 5T. And the most important point of team approach also for having close loop communication, which prevent fatal mistakes and alert the team leader and the CPR coach for any missed points during CPR. What they de-escalate or de-emphasize in the new guidelines that hit up CPR didn't show any beneficial effect, and mechanical CPR is only recommended during specific scenarios, like if the patient has long transfer for PCI or during ECMO. And there's no rules now of pericardial thumb or cuff CPR. They didn't find any beneficial effect on that. Neurological recovery remains the ultimate measure for success of resuscitation. So the new 2025 guidelines recommend to delay any prognostication, diagnosis or images, at least to wait for 72 hours after return to normothermia. And they de-emphasize to treat any myoclonus except if supported by EEG monitoring. As if we treated myoclonus without any EEG monitoring to prove there is seizure or no, this will lead to over-medicate patient with sedation that will delay the improvement and decrease the outcome. So delay any prognostication imaging except after 72 hours after return to normothermia. Let us talk about the unstable tachycardia algorithm. Unstable rapid ventricular response, atrial fibrillation or atrial flutter, and we decided to give or to deliver synchronized cardioversion for that patient. The old rule to give escalating doses of shock, but new 2025 guidelines emphasize to give higher dose synchronized cardioversion biphasic more than 200 joule, as higher as we can, to decrease the time needed to return for the sinus rhythm, and also for higher chance of success. The message is clear: don't waste time with low energy shock for unstable atrial fibrillation or tachycardia. Start effectively. For bradycardia algorithm, atropine is still the first step, but in 2025 guidelines, they emphasize about the early escalation to transcutaneous pacing or infusion of vasoactive drugs like dopamine or epinephrine. And also for patients with high-grade AV block, escalate quickly to transvenous pacing. The aim is to stabilize patient quickly in timely manner and prevent deterioration to cardiac arrest. So let us apply what we learned today on two big ED media code. The first scenario is a patient with VF arrest, witness collapse, and VF on the monitor. It is shockable rhythm. The new guidelines says what? So early shock delivery is the main treatment here. Deliver shock as soon as possible, and high quality CPR is the cornerstone, and give only epinephrine if failed shocks. What about the other R? If the patient has PE arrest, let us say patient is female, collapsed, and she has PEA on monitor, non-shockable R. What we'll do? We'll apply or give epinephrine as soon as possible, and followed by high-quality CPR, then think about the reversible causes. Using ultrasound here is very important to diagnose any signs of pulmonary embolism, any pericardial tamponade, the left ventricular function. This highlights actually the main important points in the new guidelines. Let us talk about return of spontaneous circulation, post-resuscitation care. If the patient has return of spontaneous circulation, our rule now immediately shifted for priorities now to maintain perfusion of the patient, keep mean arterial blood pressure more than 65, by vasopressor infusion immediately. For oxygenation, maintain oxygen, titrate oxygenation down to avoid hyperoxia and to prevent hypoxia. And carbon monoxide should be maintained normal level, prevent hypercapnia. And for temperature, initiate temperature control immediately. And the most important point, to prevent fever. These measures emphasize or lead to good neurological outcome, which is our aim. At the end, if we wanted to summarize what we said in a one simple message, the new adult cardiac life support guidelines focus on fewer distractions, better basics, stronger systems, achieved early IV access as soon as possible, prioritize electricity over epinephrine, high quality CPR, maintain a cornerstone, great team approach, high quality post-resuscitation care. Our aim to have a good neurological outcome survivors that will be the success of our resuscitation. Thank you, and I'm happy to be with you today, and welcome for any questions, any explanation needed from me. I'm Amr Moheen, consultant in emergency medicine and clinical associate professor, and welcome to World Institute of Critical Care and Emergency Medicine. Thank you.
Thank you, Dr. Amr. It's a really nice presentation highlighting the new updates for the 2025 guidelines. It's my pleasure now to introduce Dr. Ahmed Sanusi. He's an emergency medicine associate consultant at IMC Jeddah, Saudi Arabia. He will highlight the importance of ACLS in children and highlight the difference between adults and children resuscitation, and make sure that we are treating children as children, but not small adults. Now, mic is yours, Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I'm Ahmed Al-Sanusi, a faculty member of the World Institution of Critical Care and Emergency Medicine. Inshallah, today we will review the most important pediatric resuscitation updates from the last 5 years, focusing on the changes reflected in the 2025 American Heart Association guidelines, 2025 European Resuscitation Council guidelines, and International Liaison Committee on Resuscitation recommendations and major review articles. Rather than reviewing the entire BALS algorithm, we will focus on practical pearls that can change what we do during our next pediatric resuscitation. I have no relevant conflicts of interest or financial disclosures. The content is based on current international pediatric resuscitation guidelines and recent evidence. Let's start with a case. A 2-year-old child arrives pulseless. Which intervention is most likely to improve survival? A. Early epinephrine. B. Intubation. C. Defibrillation. D. High quality CPR. Keep your answer in your mind and we will come back to it at the end. Most of us can enumerate the pediatric algorithm from memory. The real question is, what has changed? What matters most? And what should we do differently tomorrow? So over the next 15 minutes, we will explore the most important updates in pediatric resuscitation, discuss how to optimize CPR quality rather than simply perform CPR, and review emerging concepts such as physiology-directed CPR and eCPR. Most importantly, we will translate the latest evidence into practical bedside pearls that can improve outcomes for critically ill child. Recent guidelines haven't changed the core principles of pediatric resuscitation, but they have shifted the focus toward earlier recognition of deterioration, optimizing CPR quality, timely epinephrine administration, better post-arrest care, and the use of physiologic targets to guide resuscitation. The first peril is understanding that children are not small adults. Adult cardiac arrest is usually cardiac in origin, but pediatric arrest is usually the final stage of progressive deterioration. The typical pathway is respiratory failure, led to hypoxia, then shock, and finally cardiac arrest. This means we have a larger window of opportunity to intervene before arrest occurs. The implication is important. The best pediatric resuscitation often happens before the child becomes pulseless. One of the strongest messages from recent literature is prevention of cardiac arrest. Children compensate well until they suddenly decompensate. When a child starts becoming hypotensive, they are already in late shock. So, again, treat deterioration aggressively before arrest occurs. If I had to choose one intervention to improve survival, it would be high-quality CPR. Guidelines continue to emphasize compression rate 100 to 120 per minute, depths approximately 1/3 of chest diameter, full chest recoil, and minimal interruptions. The biggest determinant of survival remains CPR quality. No medication can compensate for poor compressions. If you can measure it, you can improve it. One major trend over the last few years is objective CPR monitoring. Historically, we performed CPR based on appearance. Now, we monitor quality using physiology. End-tidal CO2 is particularly useful. Values above 20 mm mercury generally suggest effective compressions. A sudden increase in end-tidal CO2 may indicate risk. In ICU and cardiac patients, arterial diastolic pressure may also guide CPR quality. This is the foundation of physiology-directed CPR. Perhaps the most important update from pediatric arrest registries is the importance of early epinephrine. Multiple studies demonstrate for non-shockable rhythm, delays in epinephrine are associated with lower ROSC rates, lower survival, worse neurological outcomes. Current recommendation is 0.01 milligram per kg IV or IO every 3 to 5 minutes. The key word is early. Every minute of delay matters. A common mistake is delaying epinephrine while attempting endotracheal intubation, central venous access, and ultrasound examination. The evidence suggests we should establish intraosseous access rapidly and administer epinephrine rather than waiting for perfect access. For many years, the culture of resuscitation was intubate early. Recent evidence has shifted this perspective. Good back mask ventilation is sufficient initially, and repeated intubation attempts create long pauses, interruptions in compression, and hypoxia. So, a well-performed bag mask ventilation is better than a poorly performed intubation. One of the most common mistakes during pediatric resuscitation is hyperventilation. Excessive ventilation increases intrathoracic pressure. This reduces venous return, cardiac output, and coronary perfusion. With an advanced airway, provide approximately 20 to 30 breaths per minute, depending on age, and avoid rapid unnecessary ventilation. Although VF and pulseless VTAC are uncommon in children, they remain highly treatable. Current energy recommendations remain: first shock 2 joule per kg, second shock 4 joule per kg, subsequent shocks at least 4 joule per kg. The principle is unchanged. When a shockable rhythm is identified, shock early. This is probably the most exciting emerging concept. Traditionally, CPR followed a standard algorithm. Future resuscitation is moving toward individualized CPR. Examples include adjusting compression based on end-tidal CO2, arterial pressure, coronary perfusion. The concept is simple. Instead of assuming CPR is effective, measure effectiveness. Using real-time physiologic data will guide your resuscitation in a better way. For example, in tidal CO2 monitoring, if it is more than or equal 20 millimeter mercury, it is associated with a higher ROSC and survival rate. And if it is more than 35 or 40 millimeter mercury, you can predict ROSC before even you will stop the cycle and before palpating the pulse. And regarding arterial diastolic blood pressure, if it is more than or equal 25 millimeter mercury in infants, or more than or equal 30 millimeter mercury in children, both are associated with better outcomes. Use CPR feedback devices to adjust the compression and the quality of the CPR. And also, there is a role of selective use of echocardiography to identify reversible causes. Many pediatric patients don't die during CPR. They die after ROSC. Post-arrest care has become a major focus of recent guidelines. Key priorities include maintain oxygenation, avoid hypoxia, optimize ventilation, treat hypotension aggressively, control glucose, and detect seizures. ROSC is not the end point. ROSC is the beginning of the next phase. The temperature story has evolved. Early enthusiasm for routine therapeutic hypothermia has softened. Current evidence supports active temperature control, prevention of fever, maintenance of normothermia. The strongest recommendation is actually avoiding fever. Extracorporeal CPR continues to expand. In selected patients with refractory arrest, particularly those with cardiac disease, ECMO can improve outcomes. However, requires specialized centers, significant resources for sure, and careful patient selection. Not every patient is an eCPR candidate, but every emergency physician should understand the concept. Not every child in cardiac arrest is an extracorporeal CPR candidate. The greatest benefit is seen in patients with witnessed arrests, short no-flow times, potentially reversible causes, and especially those with underlying cardiac disease. Outcomes are generally better for in-hospital arrests, where ECMO can be initiated rapidly by an expert team. The key lesson from recent literature is that successful eCPR is not simply about having ECMO available. It is about selecting the right patient at the right time. Let's return to our opening question. What intervention most improves survival? The answer is high quality CPR. Everything else, epinephrine, airway management, defibrillation, extracorporeal CPR depends on effective compressions. Children rarely arrest without warning. Recognize deterioration early. Perform excellent CPR. Administer epinephrine promptly. Avoid ventilation errors and continue aggressive post-ROSC care. Those remain the pediatric resuscitation pearls that matter most. To conclude, if there is one overarching message from the recent pediatric resuscitation literature, it is that outcomes are determined long before the arrest and long after ROSC. Our goal should be to recognize deterioration early, prevent arrest whenever possible, and when arrest does occur, deliver high-quality CPR with minimal interruptions, early epinephrine, objective monitoring of CPR quality using tools such as end-tidal CO2, and avoiding common pitfalls like delay medications or hyperventilation can make a significant difference. Finally, resuscitation doesn't end with ROSC. Post-arrest care, physiologic monitoring, and advanced therapies such as extracorporeal CPR are being increasingly important parts of the resuscitation continuum. If you remember only one thing from today's talk, remember this: excellent basics save lives, and everything else builds upon them. I encourage you to review these references for a more detailed understanding of the evidence discussed today. Thank you so much for your attention and your commitment. I'd be delighted to answer any questions. Assalamu alaikum wa rahmatullah.
Alaikum salam. Thank you, Dr. Ahmed, for the nice presentation. Thank you, Dr. Amr and Dr. Haytham. I really interested in those presentations, learned a lot. Now let's move to the questions and answers. I think the first question for you, Dr. Amr. I have a question. What's the difference between hemodynamically stable patients with atrial fibrillation, the difference in synchronized shock in hemodynamically stable patients with atrial fibrillation and synchronized shock in unstable patients?
If you can hear me?
Yep.
Okay, if I understand the question correctly, and correct me if I'm wrong, that the patient with rapid atrial fibrillation or atrial fibrillation with rapid ventricular response either will be stable hemodynamically or unstable. Stable, most of us know that. Instability has some criteria, like the patient with this rapid rhythm and has severe chest pain, or in heart failure, pulmonary edema, or conscious level is affected. So this is instability. At that time, we should intervene quickly with shock, but it is synchronized cardioversion. Synchronized cardioversion that we aim to deliver the shock in special time, not to cause any harm, not to go in details. So this is a criteria of instability. If the patient is stable, we can treat them with medication or or sometimes early evidence that goes with also synchronized cardioversion with sedation, but we are not in hurry to stabilize that.
I think maybe Dr. Dina, she is asking if you are going to do the synchronized cardioversion for unstable compared to the stable patients. Maybe the unstable patient, as highlighted in your presentation, we go higher, like we go to 200 joules.
Yeah, the new
as
guidelines that said go higher as you can. If you can go to 100 joule synchronized cardioversion from the first start, not like before to escalate the joules. For a stable patient, no clear guidelines, as far as I know, that to start low, then escalate up or go higher.
Yeah, a small trick for me I'm using for stable patients. If I decide to go for a synchronized cardioversion under conscious sedation, I'm checking the all patient notes or electronic medical records. For those patients, if they have frequent cardioversions, I'm checking if they successfully reverted on 150, I'm starting with 150. If they fail to achieve it at 150, I'm going higher.
Yeah, what worked last time, we will start with it. Yes, I agree with that.
Okay. So I have a question in patients arrested outside hospital. When we will not doing CPR other than DNR cases?
Sorry, again, the patient arrested outside the hospital?
Yep. When we will not be doing CPR other than DNR cases.
Other than DNR cases. So let us start. If the patient arrested outside the hospital and we have a bystander person is ready and is trained or at least knows about CPR and he start on time cardiac compression would be best time to do. If the patient reach the hospital without any bystander CPR, I might have doubts that I will start, especially if the transport time is long. So we have time from arrest to the start CPR, which will decide when not to continue CPR or not to start CPR. In ideal situation, if the patient has bystander CPR on the spot and ambulance or EMS brought the patient directly to the hospital, I will continue CPR as good quality CPR is going on since arrest.
Yeah, I think so. Every patient should have high quality CPR other than DNR cases, except for maybe safety issues. If it's unsafe for the scene, if it's not safe to approach the patient, just ensure safety, then start CPR.
Yes.
I have a couple questions about the scholarships and if the scholarships opportunity to low-income countries. So far, the board didn't decide about it, but if there is any update, we'll be pronouncing it in the upcoming meetings, inshallah. Next question is CME hours for the meeting. Yes, each participant will be provided with a certificate of attendance. I have a question for you, Dr. Ahmed. A dose of epinephrine in pediatrics.
The dose in the pediatric, it is 0.01 milligram per kg from the concentration 1 to 10,000. We will give 0.1 ml per kg, maximum 1 milligram. like the other dose, 1 milligram as a maximum.
Thank you.
This is the usual dose, yeah. And you can give it IV or IO.
Thank you, Dr. Ahmed. Dr. Haytham, what's the double sequential?
Yes, double sequential. Actually, this is one of the three methods used now to treat the refractory ventricular fibrillation. Sometimes you have a patient who is not responding. He is a witnessed arrest, maybe cardiac. He has ventricular fibrillation and not improving. So there are a lot of trials. One of them is the double sequential using double defibrillators at the same time, or sometime vector defibrillation is changing the position from one below the right clavicle and the other below the left axilla to anterior and posterior. And another technique is elevating the head to improve the cerebral perfusion. All of these techniques are trials to resolve the issue of refractory ventricular fibrillation. But till now, it is not, it has no priority over the standard defibrillation and high quality CPR.
And that comes to the next question. What's the leg heel CPR? Is the leg heel CPR part of the 2025 guidelines, Dr. Haytham?
Actually, I have no idea about this. I didn't read in the guidelines. If anyone can have any other idea, but I have no idea about this.
Dr. Amr or Dr. Ahmed, have you heard about leg heel CPR?
No, they didn't mention in the new guidelines.
So I have next question. How about the transesophageal echo for atrial fibrillation before cardioversion? Is it still encouraged or according to stability?
Yes, actually, it's not in the recommendation of the guidelines in the atrial fibrillation. But if the patient is stable, now you will do the cardiac consultation and you may do more investigation. This is advised after the stability or after the risk of the patient. They advise early cardiac intervention, including investigation and early PCI in some patient you have coronary disease or something like this. So after stabilization of the patient, you can do more investigation, including POCUS, including transesophageal echo, and including intervention like PCI.
Thank you, Dr. Haytham. For the current recommendation or current practice for atrial fibrillation, if they are unstable, you will go for cardioversion. If they are stable, still history makes a difference. If you are sure about the exact point of when they shifted from sinus rhythm to atrial fibrillation, latest guidelines according American Heart Association, if it's less than 48 hours or more than 48 hours. If you are sure, if it's in the last 12 hours, 24 hours, there is no rule for even transthoracic echo, transesophageal echo. It's not in the guidelines. If the patient is anticoagulated and they have paroxysmal atrial fibrillation, it is safe to do it even without the transesophageal echo. I have cervical plexus block in your sorry, it's sympathetic, maybe sympathetic cervical plexus block.
Actually, advanced intervention, even the central line, they don't recommend during the resuscitation. Even the nerve block or plexus block has no rule during the resuscitation or the new guidelines.
Perfect. Question from Dr. Salah Dean to Dr. Ahmed. In infants post-TROSC, what's more important, diastolic or MAP? and what's the cut-off number recommended?
Actually, this is a very brilliant question because we had this discussion like a week ago on a case. We resuscitate a baby, and I'll go directly to the answer. During resuscitation, as we mentioned in the lecture, if you have intra-arterial line, you can look for diastolic blood pressure more than 25 in infant and more than 30 millimeter mercury in a child. Once you achieve BROSC, don't look at the diastolic. We have an equation for the minimum systolic blood pressure, okay, which is when if the child from 1 to 10 years, it's 70 plus 2 multiplied by age. So, for example, if he's like 5-year-old, it will be like 80, his minimum systolic blood pressure. Try to be always above the minimum systolic blood pressure to achieve a MAB more than or equal 55 to 60 millimeter mercury. Okay, we will not look at for the diastolic. We will try to target a MAB more than 55 to 60 millimeter mercury by achieving numbers above the minimum systolic blood pressure. I hope I answered your question.
Thank you so much, Dr. Ahmed Senousi and Dr. Amr Muhin and Dr. Haitham Khalifa for the great presentations. And thank you so much, Dr. Muhammad Abbasi, for the great moderations. And of course, thanks for all of our attendees today, more than 200 attendees who were patient with us for over 1 hour, 20 minutes. So all attendees should receive certificate of attendance by next week. And everyone should get the YouTube link of our today's recorded webinar, hopefully by tomorrow. Please stay tuned for our next month webinar on ATLS, Advanced Trauma Life Support. We'll give you more information. Probably it will be on July 13th, same time. If you are interested to join the fellowship, please go ahead and take advantage on the 10% discount using promo code webinar 10. With that, we are going to close the webinar and see you next month. Have a good rest of your day, good afternoon, good evening, good night. Bye.
Thank you.
Thank you.
Thank you. Assalamu alaikum.